Hi Eva, thank you for giving me the opportunity to ask you some questions. My first question would be, what is your biggest achievement in your research until now?
Okay, well, thank you. So I've always been interested in pain modulation, and one of our biggest achievements was when we saw that fibromyalgia patients actually have dysfunctions in endogenous pain inhibition. But I would say one thing that I really value in my own research is that we could show that this is not specific for fibromyalgia, but we also see it in patients with nociceptive pain, such as osteoarthritis, and that it's reversible, because that really led our research and other research groups' results led to a totally new research area.
Yeah, okay. And what would you describe as being the biggest impact of your research until now?
Well, I think it leads up to the nociplastic pain concept, which basically is that some kinds of pain can be better understood as a disease in its own right, rather than just a symptom, and that is due to the dysfunction of, the altered nociception. I think that is relevant also clinically, because you can explain to the patients that it's a pain modulation that is abnormal, and you don't have to search for peripheral causes with further examinations and so on.
Okay, and did you experience any obstacles or something within your research or your achievement?
Well, you could say that. I think it was like 5 years ago or so, I still got the question, so you're a believer, meaning that you believe fibromyalgia exists. So yes, I feel that there has been quite resistance to accept this new way of thought. It's nothing, of course, personal against me. I think this is always a case when you try to move the field forwards. That will always happen then.
Yeah, I totally agree with you. You already told me something about the nociplastic pain mechanism, but how would you describe specifically the difference between a nociplastic pain mechanism and central sensitization at the other hand? It's difficult. It's something even I have some difficulties with it.
That's a great question, and thank you for posing that. Central sensitization, that is a physiological term. The symptoms of central sensitization in the clinic are allodynia and hyperalgesia. And you have sensitization, you can have that in all types of pain. So you can certainly have it in nociceptive pain due to ischemia or inflammation or damage, tissue damage. You can have it in neuropathic pain due to disease or a lesion of the nervous system. And you certainly do have it in nociplastic pain, although the cause of sensitization in nociplastic pain is not very well understood.
Okay, thank you. That's a bit clearer now. You recently developed a flowchart regarding the recognition of a dominant nociplastic pain mechanism. In your opinion, what are the most important criteria, you think?
So basically, it has to be chronic, so more than 3 months. And the pain cannot entirely, of course, be explained by nociceptive or neuropathic pain mechanisms. But you have to have altered nociception, and that is pain hypersensitivity. For example, mechanical allodynia, dynamic or static, or allodynia to heat and cold, or to movement, and so on. So at least one of those criteria. And then you can say that the patient has a nociplastic pain. Then, of course, we also have a grading system. So to say that a patient has a probable nociplastic pain, you also have to have a history of pain hypersensitivity when you ask the patient, and you have to have some of the comorbidities that we list.
Yeah, okay, thank you. Why do you think it is important that we do pay attention to the dominant pain mechanism in chronic pain patients?
Well, the thing is that when dealing with pain patients, we need a diagnosis and we need pain analysis. So for example, a patient with rheumatoid arthritis can have all kinds of pain. They can have nociceptive pain, which they often have. They can have neuropathic pain. They can have nociplastic pain. Of course, it's important to know that that particular patient has a rheumatoid arthritis disease, because that needs to be treated. But when you treat the pain symptomatically, it's a type of pain that will guide you, especially for the drug treatments, but also I would say partially when it comes to physiotherapy.
I do agree with that one. For you, what is your biggest goal within your research for the future?
Well, so you asked me about the biggest achievement, and the focus of my group's research right now is neuroinflammation and the neuroimmune interface. And I do suspect that the inflammation that we see in CNS is not only driving the pathological mechanisms, but can actually perhaps also be a protective mechanism. And if we would succeed to understand this a little bit better, maybe that would open up for totally new treatment strategies. So that is sort of my goal for the future.
Do you already have some specific upcoming research ideas, or?
Yeah, so I mean, we have published quite a few studies on this. For example, linking symptoms in patients with knee osteoarthritis to neuroinflammation, but surprisingly, we see the reversal of what we expected. So we expected that high levels of pro-inflammatory substances in the cerebrospinal fluid would go with more intense pain, and we see totally the opposite.
That's surprising.
Quite a few proteins that are associated with reduced pain, and none with augmented pain. And that this, of course, started us to also examine other patient groups, and we see similar pathways there. And we also, of course, go for to look at glia cell activation, because that is a likely source of neuroinflammation. We have seen that fibromyalgia patients, for example, do have glia cell activation. So I think this is a promising field.
Okay, okay, thank you. Then I have a last question for you. I'm a physical therapist. If you could give some advice to clinicians out of in the field, what would be your advice regarding your research until now?
Tough question. So I would say when dealing with patients, listen to the patients. That's how I started out, actually. There was this huge group of patients with fibromyalgia, and they told the same story. And by following what they said, they actually gave us a clue to the concept of increased pain sensitivity. So I think, regardless of profession, if you listen to the patients and then try to analyze what they are saying, and if something is recurrent and what that could potentially mean, I would say that is a good advice.
Okay. Okay.
But you don't have to believe the patient's explanation for the pain, because that might not be correct, but their description of their symptoms and life situation, I would say.
Okay, I'll take that into account. I would like to thank you a lot.
Yeah, thank you very much.
Thank you.
It was very nice. Thank you.